Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
Hey, and welcome back to the Docs Who Lift podcast. It's been an interesting week. I just got back from Obesity Week, which is the Obesity Society's yearly conference where a lot of the top obesity researchers and physicians and the like present. I presented a couple of years ago. It was a debate of resistance training versus aerobic training in the realm of these new medicines. And this year they actually, my brother's colleague and my colleagues, I should say, a few of them.
Many colleagues.
Presented some really cool data on tirzepatide. Finally, we have some long-term data. The SURMOUNT trials went to 72 weeks? Is that the usual? 72 weeks. And this time they brought it out to a little bit more than 3 years to show.
3 years and 4 months.
3 years and 4 months.
And you said specifically it was only those people from SURMOUNT 1 who had prediabetes.
That is correct.
Because it's not quite published yet. By the time we share this podcast,
it should be
published. God forbid we don't need to get in any more trouble.
Yeah, although we weren't the ones that made the slides and presented them, so it should be.
And they're literally the ones that are going to be published in the New England Journal of Medicine. So,
what else happened this week? Anything
else
happened?
It was otherwise a pretty quiet week. So, not much going on in the world. So.
Oh yeah, we'll get into some politics at some point.
Oh dear,
but not today.
We'll see. Well, it depends. I mean, hey, we want to make America healthy again.
We do.
I think we need to do it Docs Who Lift style. We're gonna have to have a whole thing on that, and maybe we should just go full political and take over.
Yeah, I think that's probably what we're gonna have to do.
Yeah,
because we can't.
If we want it done right.
You gotta do it yourself.
Do it ourselves. Oh God.
So here's what this. So tirzepatide, if anybody remembers. So actually, I just got the reminder 1 year ago today. Zepbound was approved for obesity. I just got the little notification on my phone from my memories. And tirzepatide, we talk about it all the time. It first came out as Mounjaro, which is approved for type 2 diabetes, but then it was approved for obesity, weight management 1 year ago. Same doses, 2.55, 7.5, 10, 12.5, 15. And the studies that came out to get it approved for obesity or weight management were called the SURMOUNT trials. And the SURMOUNT 1 was the big one that came out. Gosh, I can't.
Well, it's been a couple of years. It was the spring of 22. Because Anya also, Yestroboff.
Dr. Yestroboff,
she's the first author. It was published June 4, 2022, and she presented it, I think, at the American Diabetes Association conference around that same exact time. And I remember because she's on a task force with me working on an obesity algorithm for a professional organization, and she was busy at the moment, and we were all excited because we're nerds and cheering her on because that's a really big deal in the world of nerds for us.
Yeah,
so,
that is a big deal.
It's really
pretty
cool
great
that she did that.
So tirzepatide, just for a reminder out there, very similar to semaglutide or Ozempic, Wegovy. However, it's a GLP-1/GIP co-agonist, twin incretin, instead of that 15% or so weight loss that you see with Wegovy, which is the higher dose of semaglutide. You start seeing a 20, 22 or so %, even a little bit higher in some cases, percent total body weight loss over 72 weeks, which is a little bit over a year. So in this, what they did was there's a step 1 extension. So that's a semaglutide, and they did an extension trial. They've done longer trials. This one was actually a pre-specified trial within SURMOUNT 1. So they actually recruited those with only prediabetes. So if you didn't have prediabetes, and we've had our podcast all about the diagnosis of it, but my brother can go over the diagnosis real quick of what is prediabetes and what is not. Normal glycemia, prediabetes, and type 2 diabetes. What is it, the criteria?
So, if you have a hemoglobin A1C, which is the red blood cells 3-month marker of average blood sugars. If it's 5.7 to 6.4%, we coin that pre-diabetes. Fasting blood glucose of 100 to 125 milligrams per deciliter pre-diabetes. And then something we should do more often, and actually was used in a lot of the older diabetes prevention trials, the glucose tolerance test, that a lot of the women we know about that, because everybody who's pregnant has to do that. And I do a lot of them in my patients with obesity and metabolic syndrome. But a 2-hour glucose after drinking the horrible syrup of 140 to 199 milligrams per deciliter is impaired glucose tolerance or prediabetes. And actually, one of the reasons we should do that more often, I don't think that's how they assess that in the SURMOUNT
They
trials
did.
that I'm
No, they
did
did.
they do that
They said
everyone?
well, that was what the criteria they put up there on the
Oh, that's
slides.
good.
I didn't send you
Okay.
the slide, but
No,
anyway.
that's actually really good, because that's a little bit more consistent with some of the older ones, and that might be why there was a higher incidence that we'll get to. So just for example, why do we even care about prediabetes? And this gets to the point where, do you ever notice online how people are like, oh my God, my hemoglobin's A1C is 5.6. I got to get it down to 5, or I got to go on a low carb diet, or I got to wear a CGM because I don't want my sugar to rise above 140 ever, even with a banana, even though that makes 0 sense. Well, the reason we care about this is because of the statistics that show the higher risk of progression to meeting criteria for type 2 diabetes, which are basically just 1 point above all those other things I just said: an A1C of 6.5, a fasting glucose of 126, and a 2-hour glucose of 200, or glucose of 200 plus symptoms, because it's at those thresholds where people dramatically have an increased risk of the long-term complications from having high blood sugars. And so it was kind of figured out essentially that people with obesity, metabolic syndrome, and this sort of transitionary period of prediabetes, that we call it, have a markedly increased risk of diabetes compared to those who don't meet those criteria. So, for example, in some of the old lifestyle trials, the diabetes prevention trial, which was very famous, 3 years, the incidence of people getting to a criteria of type 2 diabetes was 29%. In kind of just the usual care arm, versus 14% in the intensive lifestyle arm, which is where we get the 7 to 10% weight loss goal, by the way. So that was nutrition, exercise, meal replacement shakes. And that was pretty consistent with all the other ones. There was a Finnish diabetes trial, and then there was a famous Daking trial in China that was actually 6 years. And we have like 30-year data from that showing reduced mortality. So, talk about, everyone's like, oh, doctors are just pushing pills. No, actually, we have great data from a long time ago that makes lifestyle intervention first line, but it is easier said than done. These were truly intensive lifestyle therapy arms, meal replacements, frequent monitoring, but that one has 30-year data showing reduced mortality recently. So that's a big deal. But back to my point was that you can see that what the incidence was in those. So, 29% for diabetes prevention program, 23% in 3 years with the Finnish. In the Daking, it was 6 years. So it was actually a 68% incidence. They had really high risk. And in this one that you're going to talk about in the prediabetes arm of the SURMOUNT-1, it looks like over that little bit more than 3 years in the placebo arm, despite good diet and exercise recommendations, they still had a 13.3% incidence of meeting type 2 diabetes criteria.
Yeah.
And I'll let you kind of spill the beans on what the treatment arm was. But as you mentioned, these medicines are very, very good for type 2 diabetes, and hence have very good sugar control. So not to be unexpected that they're really good for prediabetes sugars too.
So I was really excited to see this presented, because a lot of people are saying, well, there's no long-term trials. So we do have the long-term trials of semaglutide, but what about tirzepatide? Is there something different? Since it is a little bit different of a peptide. It hits both that GLP-1 and GIP receptors. And it's like, okay, it looks like it's good on paper. People are losing weight. Glycemia looks better. Lipids look better. But what actually happens over the course of years instead of just a year or so, a little bit over a year? And so it was, I got to look at the numbers here a little bit. I have my little slides. Of course, it's not published yet. And so I was taking pictures of the slides. I don't know if that was illegal or not, but
it was like 250 to 270 people per arm. So per dose of the tirzepatide and the placebo.
Because so the 4 arms. The 3 different doses were 5 milligrams of tirzepatide, 10 milligrams, and 15 milligrams. And so the first thing they started showing, they didn't talk about the diabetes prevention stuff, or progression stuff in the beginning. The first thing they showed was the weight reduction over 176 weeks, so 3 years, 4 months. And just like we saw in Surmount 1, we saw, let's see, the 5
milligram
group
probably do that first. Okay. So the placebo group got 2% weight loss.
Yeah, about 2%. So that's about what we'd expect.
Classic, right?
Which, you know what?
Every trial.
And you know what? They actually, instead of regaining it all, it looks like they kept it. It was kind of stable. They kept it off at least, which is kind of interesting.
Yeah, and that's people don't realize that's relatively impressive, because even just a few % weight loss is difficult for people to maintain because of that biology. Especially people who get into these trials, they've been struggling. They're not just random people that are like, oh, I want to go get in that trial. They're real. Patients struggling, and these people have prediabetes. It's not just some metabolically healthy little bit of weight struggle. This is significant weight.
And the presenters did reiterate that the placebo arm was lifestyle. So essentially, we're just looking at lifestyle versus lifestyle plus these drugs. Mm-hmm. Now, was it intensive lifestyle? No, it's not intensive lifestyle, but decent enough lifestyle where you'd get probably better than usual, physician out there. Mm-hmm. So the 5 milligram though. Dose got down to around 15.5%. So that's very similar to what we see with the highest dose of Wegovy or semaglutide. So that's the 5 milligram dose. And just like in the Surmount 1, we saw them keep that weight off. So you see this we can't show the graphs in this
very
podcast.
Stable though. It got down there at about 60 weeks and it just stayed there.
You don't see any like slow coming up. No, it's just there. Mm-hmm. So that's the 5 milligram dose. The 10 milligram dose got to almost is 19.9, but almost 20% total body weight loss. And then that was 10 milligrams. And the 15 milligrams is almost 23%. And again, these people lose the weight and they just keep it off. Now, what we always hear is that people start talking about their appetite. It loses that effect. But despite people's appetite, they subjectively say their appetite's going up and the food noise is coming back, they still keep the weight off, which I think is interesting. And they did mention this at the end. I don't have the slide, that people do mention their appetite starts coming back, but they keep the weight off, which I think is interesting. So I don't know what's going on there exactly, but I think that's pretty cool.
Yeah. And the categorical weight loss, again, I like to point this out because we know that certain thresholds of weight loss correlate to health benefits. So just like in these diabetes prevention trials, both with lifestyle, metformin, semaglutide or Wegovy, and even Qsymia, which is phentermine topiramate, it was very much correlated to that 7.5, 10 or more % weight loss. So that really is our standard these days. The old standard of 5%, darn near 100% of people on the tirzepatide were able to achieve that. But 71, 80, and about 90% were able to get 10% weight loss of those 3 doses compared to only 10% of the people in the lifestyle arm. And then 2/3 to 80% of people were able to get 15% weight loss on the 10 and the 15% tirzepatide. I mean, and going, half the people, more than half the people were able to get 20%. Only 2% of the people in the lifestyle arm got 20% weight loss, mind you. So, this does go to show that there were a few people in this trial who got extraordinary weight loss with lifestyle. So it can be done. Yeah. So we don't need to say, oh my God, everyone needs these meds, but it was 2%. And
look at the 25%.
I know. Look at that. I mean, so that same 2%, apparently, were almost 2%, I guess, were able to get that in the placebo group, but 16% in the 5 milligram, 33% in the 10 milligram, and 43% in the 15 milligram of tirzepatide, Zepbound, were able to get 25% weight loss, which is basically like bariatric surgery level stuff.
So to put that into comparison, if you're 200 pounds, probably going to be higher if you're getting this drug, but it depends on how tall you are. So let's just say you're 200 pounds. You just lost 50 pounds. That's pretty good.
Yeah. And we have to really emphasize, I think, what do these goals mean? Because we still know that a lot of people want more weight loss than is what is clinically necessary for their health goals, and maybe sometimes, realistic, especially if we're talking about lifestyle, as we just went over. I mean, yeah, a couple percent were able to do that, but people shouldn't feel like failures if they're able to get 5-10% weight loss with lifestyle, and certainly if they can get more than that with medications, they need to be proud of themselves, because it's literally what's on the inside that counts, and that's what we're talking about: diabetes prevention, cardiovascular risk reduction, and then I think we're going to mention one more study later on today that we haven't gone over yet about even knee arthritis.
Yeah, before we get into the diabetes progression, I do want to talk about how they made an off-drug follow-up of 17 weeks. So they took people off the drug at week 176, and then they followed them to week 193. So 17 weeks, just over 4 months. And they wanted to see what happens to these people.
Oh dear.
Yeah. So what happened to these people? They regained on average 7% of their body weight. And this is actually seems to be more rapid weight regain compared to some of the other trials that they've done. And you'd think that the longer you're on this, maybe the longer you figured out the habits and whatever to of nutrition and whatever else you're doing to keep the weight off. But it seems to be more rapid weight regain once you come off the medicine. Now, again, I'd have to look more granular when the study comes out to see. Not everybody probably did regain the weight like that, but a lot of people did. And so 7% over 17 weeks that's a lot of weight regain.
Yeah. I mean, unfortunately, when you lose a lot of weight, let's say without the medicine, let's say those 2% of people, maybe even, the body's biology works even harder to try to regain the weight. And so the people who truly need the medicine and respond this well to the medicine, and then suddenly get off the medicine, you can imagine how much more dramatic that body's biologic drive to regain the weight probably is. I mean, I'd hate to see how they feel at that point. I mean, they might feel like they're starving, the food noises overwhelming them. We live in this shitty food environment that that we need to make America healthy again about. Easier said than done in politics, but it's a problem. But this is why these are chronic medications for a chronic disease process, and that's why we need these long-term studies, so that we all do feel comfortable that, hey, yeah, the benefits outweigh the risks.
So why don't you get into the diabetes progression stuff, and then we'll get into the cool stuff that we like as well, which are the adverse events that were reported. Which, again, I like the SELECT trial. We talked about this when it came out. It was actually a year ago about that. Just as much as the results were cool, the looking at the long-term side effect profile is also cool to make us like, we don't want to cause any issues. We need to have the benefits to be more than the risks. And in this case, I'll get into it, but they definitely are. So if you can look at the slides for diabetes progression.
Yeah. So just like in those former trials that I talked about, the placebo arm, and again, it was 270 people who had the pre-diabetes. Over those 3 years, the incidence of diabetes was about 13%. So 34 of the 270 ultimately were diagnosed with type 2 diabetes. In a pooled analysis, so this is both, this is the 5, the 10, and the 15 milligram doses of tirzepatide. Only 9 of 762 were diagnosed with type 2 diabetes, and that's 1.2%. And so, from a statistical perspective, that's a 94% risk reduction in the progression to diabetes. Now, I am going to get on my soapbox a little bit, because some of this gets into semantics of how we define diabetes. So historically, as we talked about, the criteria for diagnosis are based upon blood sugars. But we know the disease is actually a lot more complicated than that. It's the obesity. It's what our body's genetic predisposition to deal with the adiposity does, and the metabolic syndrome, the insulin resistance, the cardiovascular disease. We've talked about fatty liver and the risk of cirrhosis, heart attacks, and all these different things. So the disease is really a lot more than just blood sugar. When I was going through fellowship, we talked about how we had to encourage all of healthcare to get away from this glucocentric approach, even in type 1 diabetes, which is very glucocentric, because blood sugars are a big deal. But in this case, remember, these medications were originally researched and developed for type 2 diabetes because they literally are incretins, meaning they stimulate the insulin secretion from the pancreas. And so they are very, very, very good for blood sugars. So, if we had someone already with type 2 diabetes who gets put on Mounjaro, tirzepatide, if their A1C is 7%, which usually the trials for tirzepatide and diabetes, the A1Cs were above 8, they also end up having sugar measures normal that are more like in the pre-diabetes range. You know what I mean?
Or normal.
They and so then this gets into, we talk about diabetes remission. Well, technically, the remission term is for people who have essentially normal blood sugars without anti-diabetes medications for a certain amount of time. And we call that a state of remission, essentially. And so if we're using these medicines, which are obviously the best type 2 diabetes medications, and they're lowering the blood sugars, whether they have type 2 diabetes or just really bad pre-diabetes, they're going to improve the blood sugars no matter what. But that's why I think it's important to look at the context of the older trials where, like, say, Qsymia, for example, the phentermine topiramate, in people with metabolic syndrome and pre-diabetes, who in just a couple of years in that trial, they had an 11% incidence of type 2 diabetes criteria. Those medications don't do anything directly to blood sugar. You know what I mean?
Right.
And they had, so their 11 to 12% weight loss versus 2.5% weight loss in the placebo arm had a 71 to 80, almost 80% reduction in the incidence of type 2 diabetes, with essentially an 11% incidence of type 2 diabetes in the placebo arm versus 2.5% in the medication arm. So what I'm saying is that weight loss really directly is what correlated to the diabetes prevention. And so between that and the glycemic benefits of these medications, I think we can feel pretty comfortable that we are treating the underlying root issue of the obesity driving insulin resistance and type 2 diabetes. And this, so the incidence reduction of type 2 diabetes is maybe a little bit more dramatic because there are direct blood sugar benefits. Yeah. But the weight loss is darn good, and it's really good for everything else. And we certainly hope and are excited to see the cardiovascular outcomes with this one, just like we were with the semaglutide Wegovy last year, and then the future medications.
Yeah, they did a little analysis in this, and a little analysis in this little trial. I believe, where the heck is it? Maybe I didn't take a picture
which one?
of it.
What do you want? I don't
they said something like the weight resulted in it. They do these analysis. It's hard to really know.
I know. They're little statistical manipulations.
Basically, that 55, the weight can be attributed to 55% of the decrease in diabetes.
Basically,
progression.
Over half of the reduction in incidence diabetes, they were able to kind of calculate that. Oh, it's from the weight reduction as opposed to the direct.
It's really hard to know that. But, I mean, they're trying to use statistical analysis, but I don't know, because again, like my brother said, these drugs they do lower blood sugars in a glucose dependent fashion, but like that's just without any weight reduction, you're going to have a benefit from these medicines for glycemia. All right. Is there anything else you wanted to say about the diabetes?
I think that's it. I think, I think you talked about the regain off the medication. These are chronic medications, very, very, very appropriate for the highest risk obesity with prediabetes. fatty liver. We'll talk about more when we have more data for that again. But I think it's important now to talk about those side effects, because these are now over 3-year data for the side effects. And this is what everybody online in Hollywood, everyone's arguing about all the time. We have the extremists, just like in politics. We won't get too much into the politics, but these extremisms are causing problems. And so we have people out there who are saying, oh, everyone should be on these, and we're going to make compounded bootleg versions, and people are getting ill off of those. And, people who don't have obesity are taking these medications. The cost is through the roof. It's causing all sorts of problems. And then there are people out there going, oh, nobody should be on them because of side effects and losing muscle. And the truth always lies somewhere in the middle, but that's not sexy, and it doesn't get a lot of traction, unfortunately. But that's the truth. So now we have almost 3.5-year data on tirzepatide in people with obesity and prediabetes. And I think you have all those slides to talk about.
Yeah. So as usual, nausea is probably the most common thing. But what's funny is that those in the placebo group, there was,
it's like 6% stopping the drug due to
12% had nausea, but I don't know how many stopped it due to the nausea in that group. But compared to like 24% in the 5 milligrams, and they show 30% in 10 milligrams and 31, there was an interesting discussion, because we always show in these trials 31%. I would actually say that's probably I don't want to say underplaying it, but it's we see it in most people, some nausea. Maybe it wasn't strong enough that people didn't feel the need to report it, but nausea is absolutely the most common, but that's to be expected. And we did see constipation. And what's funny, actually, they showed a graph. I didn't show it sent it to the slide to my brother, but nausea, you see in the graphs, it shows a spike in the beginning of the trials. And that's what we see clinically. You see the spike in nausea, and then it just kind of slowly resolves over time.
No, you did send it. Yeah.
Did I send you that one?
Yeah. And so this is what we saw in a lot of the other, remember, these medications have been around since I was a med student. They've been around for 20 years. And so we've always known that the nausea that people feel early on, we tell them, if you can weather the storm, it should go away. And it's not the nausea that helps people. A lot of people used to think, oh, I get nauseous, so I don't eat, so I lose weight. But that's not true. So the people who don't get nausea get the same benefits.
Yeah.
But yeah, these graphs nicely show that. I don't know how the placebo group had so much nausea in the front line too.
I don't know.
So placebo is a powerful thing. That's why we have placebo groups. That's amazing. But yes, so there's a spike, and then you can see these little spikes every time the dose goes up. But over time, it all ends up going down to darn near zero. So a very small percentage at the end still had nausea, and essentially nobody had vomiting other than a few people early in the beginning.
Diarrhea a little bit. But look at constipation, though. That's the one that I wanted to.
Yeah, so a lot of constipation.
It's not
Water
a spike.
my ass. Get this guy some Pepto-Bismol.
It's not a spike. You see a spike, but it remains.
It's a plateau.
It's a plateau.
Not a spike.
So I guess I'm saying spike because it's like at day 0 you see the spike. So when they show this constipation graph, the placebo gets somewhere around 3% or so. And that kind of stays around there.
Yeah.
But
how does the song go? Nausea,
heartburn, indigestion, upset stomach, diarrhea.
All right. Yeah.
So then you see for this one, 5 milligrams, 15 milligrams, all of them have constipation. So, and it keeps going. So, this is kind of like one of those things where, hey, we counsel patients. Ideally, you'd have dietitians helping along with this, but a lot of fluids, lots of fibrous foods, and lots of physical activity will help you keep regular. Add some orlistat in there. We need to do that trial. I bet we could. I might be able to do that trial.
I could. We could.
We could do that if we want.
We could do it.
Okay, so for all the other side effects that people care about, like the bad stuff that people are worried about, let's see what we got here.
Well, this gets into the primary reason for discontinuation from the drug. So the bad stuff is going to be in there, like pancreatitis.
Where's that pancreatitis?
Nobody in the 15, nobody in the 10 milligram. Somehow 3 people in the 5 milligram tirzepatide, and then nobody in the placebo group. So
are you looking at which one are you looking at? I'm looking at adjudicated confirmed pancreatitis. Has 1 in placebo, 2 and 5 milligrams.
This
1
was
and
for
10.
discontinuing the medication. Yeah,
I'm just looking at. Okay, so no statistically significant difference, which people talk about pancreatitis, but we've talked about this before. There are different types of causes of pancreatitis. One of which, alcohol, which a new paper. We'll talk about the paper I'm getting published here. I think it's actually in a couple of weeks. It's getting published, but talking about alcohol.
About time you got your ass published.
Yeah, now Jesus. I got 2 papers. I got I got 2 papers.
No, because I got you on
like
gym clinic.
Yeah, but the 2 data.
You mean
a
trial?
It's not even a trial. It's retrospective data based off of the sequence.
Still cool.
Yeah, it's still cool. So anyway, alcohol. So these drugs reduce the intake of alcohol. Alcohol is one of the major causes of pancreatitis. So that's nice. What about triglycerides? That's another cause of pancreatitis. Usually triglycerides over 1,000. 500 is the number, but 1,000 is where it really goes up, milligrams per deciliter. So what does tirzepatide do? It helps you greatly reduce your triglycerides, not only from fat loss, but there's some really cool stuff it does with lipids. But one thing it can do is increase, and this is what we're going to get into here, it can increase your risk of gallstones. And I don't know how many times we've talked about this, probably once every other episode. The medicines help you lose a lot of weight. Weight loss, rapid weight loss can change the mixture of your bile. Bile is what helps us with digestion. It's stored in your gallbladder. If you change the mixture of it, you can precipitate stones. And that can happen with quick weight loss. And we do see what they showed here were an increased risk of cholelithiasis. Now, they didn't, gallstones, but they don't actually show, it's really interesting, they don't actually show an increased risk of cholecystitis. It's just cholelithiasis.
Well, but then they have they just have a very generic parameter called severe or serious acute gallbladder disease, though.
Here, no, I'll show you. Let me send you this.
Together.
There's a, they show,
you can just read it.
No, they here, let me show you. No,
I see that one. It breaks down the gallbladder related disease.
Okay, okay, yeah. I didn't know if
I'm saying in the slide before, it has just the generic severe or serious acute gallbladder disease, and it's 0.7% in the placebo, 1.2 in the 5 milligram, 3.8, 3.6, still very small numbers, essentially single digits. That's overall. So then what you're talking about is what type of gallbladder disease, because these medications, there's something else, there is some sort of gallbladder.
It might change the motility of it. Nobody's sure exactly.
But the stones, it was 5 people in the placebo arm, 5 people in the 5 milligram arm, 8 in the 10 milligram arm, and 9 in the 15 milligram arm. So most of it was gallstones. But then there was one person in each arm that had the cholecystitis, the inflammation, the acute cholecystitis, chronic cholecystitis, but minimal.
Yeah,
overall.
So pretty cool. I don't know. I'm sure. Have you seen? I've had a few patients had to get their gallbladder taken out.
Not a lot though. I think probably maybe similar to the statistics we've seen. So I think if we look back at the SELECT trial, the big cardiovascular outcome trial with Wegovy, it was something like 1 versus 1.6% had gallbladder disease. So it sounds really small, but it's actually statistically significant. So it's a real risk. This is one of the true real risks we talk about, even though the risk is low. Whereas a lot of those other risks that you can go through that people, scaremonger everyone about, they really aren't necessarily high concerns based on the statistical analyses of these trials, right?
Yeah. So
really,
there you go.
Really darn safe overall.
3-year data.
3.5 almost. 3 and a third. So,
all right. There you go. Tirzepatide. Set it, forget it. Works really well.
Zepbound.
Yeah. Great drug. One of the greatest drugs. In fact, it's so great. It's one of the best. Everything else is terrible. One of the worst in history.
Oh, God.
All right. Anyway, let's go to the Step 9 trial real quick. And this is obvious. One of our friends, he's been on the podcast, Dr. Bonakis, Alex Bonakis. He's another endocrinologist, obesity specialist. We have all these chat groups, but we're laughing because it's water is wet. This was a trial that looked at basically pain in the knee with those with osteoarthritis and obesity, and to see if semaglutide would have an effect. Now, I will say there are metabolic. The ortho guys the good ortho guys will talk about this. How it's not just weight and wear and tear and mechanical pain. There's probably a metabolic effect of joint pain. Having said that, we'd expect those with osteoarthritis and obesity in the knee that pain would improve with weight loss. And
yeah,
so this
this is not
trial.
the first study to show that. I mean, we have a lot of good data from other trials of weight loss and knee arthritis, especially bariatric surgery. I mean, and this is one of the things that, we'll even have in our clinical algorithm, that weight reduction goals for people with knee arthritis are going to, really more than 10%. So it kind of comes back to that. So I think this was a cool trial. So it was recently published. We didn't get to talk about it yet. And, certainly it's probably because, Big Pharma wants to get another indication for it, I suppose. But the results are true. And so they had people with obesity and severe, I think it was mostly severe knee arthritis, if I'm not mistaken. But it was 68 weeks, it was a randomized controlled trial sort of thing. And they were randomized 2-1. So, two people getting essentially Wegovy for every one person getting a placebo subcutaneous injection. They still had counseling on physical activity, a reduced calorie diet, and they had what they call, and I don't know about that. We should have had an orthopod on this to talk more about it, but Western Ontario and McMaster University Osteoarthritis Index. We could have
McMaster, isn't that
could have asked
Phil?
Stu Phillips.
Yeah.
Yeah.
There we go.
All right, Blitz. All right. Pain score. Anyways, it's a pain score on a scale of 0 to 100, with higher scores reflecting worse outcomes from baseline to week 68. And they had some other key confirmatory secondary endpoints: physical function, a 36-item short form health survey, they said, etc. So, and this wasn't a huge trial, mind you, but it was lots of them. 407 participants were enrolled, 56 years old. The BMI was 40. So that's a pretty large, high BMI compared to some of these other trials that we talk about with these. So that's a high BMI. And the bottom line is the weight loss on the semaglutide or Wegovy after 68 weeks was about 14% versus a little over 3% with placebo. So again, not bad diet and exercise group. So that's not bad. But then the mean change in that special pain score that I just mentioned at week 68 was a minus 42 points with the semaglutide versus 27.5 points with placebo. The semaglutide group had much greater improvements in the physical function, which means not only do they feel better, but now they're suddenly able to do more exercise. And this point scale was 12 points improved versus 6.5 points improved. Very statistically significant, though. There weren't any adverse, events of concern between the two groups. Yeah, and that's kind of it. And so very, very good for people struggling with knee arthritis. And I know a lot of orthopedic surgeons who do knee replacements, they really like to see really good weight loss going into knee replacement because they have better outcomes after knee replacement too. So it goes both ways.
Yeah, this goes into the whole, like, I can't believe people are using these drugs as crutches. Let's get people to eat better and exercise so that they don't need to use these drugs. It's like, no, the drugs allow people to do those things.
Yeah.
Whatever you may think, whatever biases you may have, the drugs work. And, you may get mad about it, but the data's the data. They work better than the placebo, which the placebo group is literally the diet and exercise only group.
There's nothing we can do about it. Sorry.
And
we
are the
shills for lifestyle.
We are the docs who lift. We don't take these drugs. Maybe someday we will because they're cardioprotective or something. I don't even know. But we don't take these drugs ourselves. We don't get paid by Big Pharma. We say it
Not yet.
Not yet.
I'm going to start speaking for one of them. Probably not these guys, though, because everyone will get mad at us. But
we get lots of offers to do it. The drugs just
the greatest offers, the best offers,
the best,
the biggest
only
offers.
The best. All the other loser doctors get the worst.
Oh God,
get the worst.
We're gonna get hate mail.
Get the worst. No, it's a joke. Everybody knows we're just joking. Let me. Okay, so I just need to talk about politics real quick because no, this goes into a lot of people are posting a picture of what's her name? What is her name? The current.
This is like the Saturday Night Live skit I just told you about.
No,
we don't know her name.
The health lady.
I know. I don't know her name off the top of my head.
That doesn't matter. I don't know if she's the head of some health something. Whatever. So they're showing a picture of her, and then they're showing a picture of RFK Jr. and saying like, see, this is why we need someone who looks like this in terms of for heading up our health, and not this other person. And they're alluding to the fact that RFK Jr. has a better physique and looks a little bit more vibrant than this other person. So I took a picture of this.
Is it? I think it's Rachel. I don't. Maybe
yeah,
I
no, that's right.
No,
that's right.
Rachel Levine.
Yeah, that's right.
Levine,
that's right.
Assistant Secretary of Health in the United States. She's not even the head one.
I know.
People are jerks. I mean, the fact that people even do this. Who knows what RFK Jr. is doing? He may be the most unhealthy person in the world. You know, people who take steroids are unhealthy, but they might look good. Maybe.
I just think it's funny. So I took a picture of this. I say, hey, you know, because people are posting all these people are posting like, hey, so yeah, this is why we need to look for our health and use people that are healthy looking and appearing, whatever. So I said, hey, you know, we've talked about this before. Let's look at the policies. Let's look at outcomes instead of, you know, appearances. And then, you know, some people are like, well, we don't like her policies anyway, and our health is atrocious. Okay, fine. Well, why don't we go for both? So I posted a poll and said, why don't we nominate my brother then as a buff doctor? And I'm getting a lot of DMs that are saying they would vote for Karl, Dr. Karl Nadolsky.
God, here we go.
Getting a lot of them. So I think this is the beginning of our political campaign here.
Oh my God!
I think we're going to see a beginning. And when I say he's got nothing to hide, he's got nothing to hide. He will show it all. We've known that.
Yeah, and apparently it doesn't matter because anybody can get voted in, so it doesn't matter.
Yeah, it doesn't matter. It doesn't matter
what we've shown in the past.
He will. It may actually help your odds. In fact, that's my campaign, and we're gonna go back. So I in high school, I was a junior, and I ran for treasurer, student senate, and my campaign was "Got Girth," and I won. I made it fine. I won. It was Got Girth.
You were the one who probably could have predicted this whole thing. You and the Simpsons.
It was Got Girth. That was my whole campaign, and I had posters everywhere. And with high school, I didn't get in trouble for it. I actually won the election. I flexed my biceps during the speech that I gave. It had nothing to do with any of my policies that I was going to do whatever. I was a 4.0 student. I actually got a B+ in AP chemistry my senior year. I did blow it. However, my speech was it was terrible. It was so terrible because all I did was flex my biceps and talked about how.
It was funny though. I was there.
It was funny.
Somehow.
It was. I just made jokes the whole time and I won. So I think we need to.
Yeah. I think time to go into politics.
Time to go into politics. Let's just mix. Right. Let's just. But we have. I think we have some good substance. We might.
Well, yeah. Because we can be the showmen and we can stick with real data and actually try to help do what's right for people instead of falling for whatever these damn biases everyone has. God.
Let's vote for Dr. Karl with his pecs and his lats. Showing them
people
off.
Don't even know you're referring to Seinfeld on that, I'm sure. But
his pecs and his lats are always hanging out. Anyway, all right. So if you have a friend, and if you got people that are worried about these drugs long term, show them this. We'll make sure we put the link to the study in the show notes. Long term tirzepatide data, osteoarthritis of the knee. Yes, if you want to try diet and exercise first, we certainly applaud that, and that's first-line treatment. A lot of people are going to still need help. Just take a look at the placebo versus the active arms. Anything else?
No, I think that's it. Make America healthy again. Docs Who Lift style.
Docs Who Lift. All right, here's our outro.
Political Action Committee.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.